Guys, welcome to Clinical Unfiltered with Dr. Sausha, and today we have Dr. V with us again. And so today I want you to give me your hearts, your minds, and your teeth, and let's get unfiltered with Dr. V as we continue down the rabbit hole of wisdom teeth. So last time we had Dr. V on, we were talking about more so procedural based, how we take out wisdom teeth or third molars. Today, I would love to just swim in shit with you and talk about when shit hits the fan with wisdom teeth extractions. Because honestly, that's probably what scares me the hell out of doing a lot of them. I want to know, out the freaking gate, Dr. V, what's the worst wisdom tooth complication you've ever had? The one that just turned, like the one that's going to make you vomit right now.
I mean, it's never a good day when your patient goes to the hospital, which, for the record, is the number one reason you should always post-op your patients, okay? Because you never know what's going on. And so I had this younger girl.
Post-op them in the hospital?
Well, no, preferably not.
But, you can do that. Yeah, I
can. Exactly. But no, you always want to call your patients afterwards to make sure things are going okay. I mean, she must have been 17, 18 years old, female. She was obese. I would say her BMI was probably about 40. Definitely didn't take care of herself, probably pre-diabetic. And we had a little bit of a bleed during the surgery, especially when you have those nerves that are really close to those immature apexes. But I thought we contained it, but then they start crying and then they start throwing up and then they get all hysterical and then they bleed more. And she just progressed to an infected hematoma within like 36 hours and ended up in the hospital with a true Ludwig's. And I had to go drain her. So for all of you that don't remember from our pathology and anatomy classes, a Ludwig angina is submental and bilateral submandibular swelling. So your tongue is at the roof of your mouth, you're choking for air, you're not breathing, and it is considered an emergency situation. And this girl was possibly going to get intubated. I had to go basically like 2 days after surgery into the hospital and do an extra oral drainage. So I had to basically make an incision in her neck, take some hemostats, go up to the inferior border of her mandible, hug the lingual and buccal of that mandible, spread it open, and just pus just drained and drained and drained. And I would say that's probably my worst wisdom tooth complication.
I mean, okay, you did that. You did it yourself, though, in the hospital. Like how? Now I know you're. I think we've mentioned this before, but you're an oral maxillofacial surgeon. So you have rights to that hospital?
I have hospital privileges, yep. And I take trauma call.
In any hospital or that specific hospital that they were at? Did you tell them to go?
Maine. I did.
Okay,
yes.
So you told the patient, go to that hospital. I will see you there.
Yes, you do not want your dental infections ending up in the hands of ENT. They have no idea what they're doing.
I don't know why, but I'm really fascinated like how that whole process goes down. So, okay, the patient checks into the hospital. They say they got
to the emergency room.
Okay, and they know to call you? How do they know? How do they know? Do they know to call you? You just know she's there, so you go there.
I tell the patient to tell them to call me.
Oh, okay, gotcha. Okay, so that's how you got like, okay, she's there. I'm coming to room, shit on a brick 39, whatever room she's in. Okay, gotcha.
Be a board certified oral surgeon, you have to maintain hospital privileges. And so we all basically have a place to take our emergencies, which is why I get very serious when we talk about complications, because if you're doing, big cases, are you ready to manage those big complications, right? Because the more difficult the case, the bigger the complications. And so at least as an oral surgeon, we have hospital privileges. So if we are in a situation, we have the place to be able to take them and not, risk their well-being in our office.
Oh, and I will tell you this too. I mean, not to say you can't do big cases, but if you do, and you do not have those privileges, you better know someone who does. Like if you're sitting there right now, like, oh man, I sling these things all day and I do not know anyone that I could trust to say, hey, help me out in a hospital scenario. Stop, go find someone, go to your local study club and meet an oral surgeon who does have privileges at a hospital. Because I have a case. It was more an implant related case. I think you've seen this case where like pus is coming out of the jaw, and it was another surgeon that it happens to be a patient of mine that had privileges at the hospital that the patient happened to be at. So I got lucky in that scenario, but like, yeah, it's good to know. Like if I have something, I'm definitely calling Dr. V to be like, hey, guess what? And telling her my fun little story. So that's worst case scenarios that you're talking about, is that Lugwin's angina. I mean, probably, okay, let's circle back to maybe what's the most common complication you run into.
After surgery, I mean, honestly, it's just a combination of dry sockets and infected hematomas. So, patients aren't irrigating properly. I had a woman who told her 12-year-old daughter not to brush her teeth for 10 days after surgery.
You.
You can't, common sense isn't so common. But, the biggest thing is basically, whatever the patient is really responsible for, right? Because it doesn't matter how many times you go over the instructions, doesn't matter how many pieces of paper you give them, they're not going to listen. And so, again, that is why I make it a point to call all my patients. I have a separate emergency line, because usually it's just they got food stuck in there, or perhaps during your surgery, you had a bleed. Maybe let's say you released a flap and the burn nicked that soft tissue and you get like a really small, like buccal artery type bleed, whatever. And you inject local numbing medicine into it. So you think it's gone, but it's not. And the patient starts bleeding again. Those can sit, and that's usually what comes up as a nodule because it gets infected secondarily. There's a few things that I like to do to help prevent these things from happening that I've kind of worked into my systems and my protocols. And so I would say my complication rate right now is probably like 1 out of 25, I would say.
Okay, but that's still not zero. That's good, but that's still not zero considering the
first
number.
First of all, if you have zero complications, you're not doing enough surgery.
But I think 1 out of 25, and that's someone who, you're someone who's like just slinging wisdom teeth nonstop. You got to imagine that though, guys. If you're like, oh yeah, I'm a doctor who does a bunch of wisdom teeth, and you take out like 6 in a day, and you think you're that. I worked alongside Dr. V. There'd be days she would be taking out like 20 wisdom teeth. So these complications are actually, I still think, honestly, more common than most other complications. Most other extraction socket, than any other extraction socket. I think wisdom teeth have the most complication rates.
Yeah, and you also have to think about the patient population. Absolutely. And you also have to think about the demographic, right? So you're getting either a younger patient or you're getting a much older patient that has that horizontally impacted one that I'm taking out, because y'all take out the easy erupted ones, right? So, if you got an older patient with this horizontal full bony impacted tooth, like no matter what you do, it's just going to suck.
Gotcha. So, it's not even a complication. It's just you're healing.
Yeah. And that's usually what it is, right? Like, and I consider a complication to be like a parent calling me concerned that their son or daughter is still swollen. Okay. I'm not saying 1 out of 25 times I got a patient in the hospital now. I'm saying 1 out of 25 times a patient calls me after that initial post-op call to ask me for some questions. And I'll maybe see 2 or 3 follow-ups in my office a month to actually irrigate people out, max.
So you said 2 most common complications, one being dry sockets. So the dry sockets from a wisdom tooth removal, what do you think, what do you think is the most underlying cause for those dry sockets on your patient?
So either the patient is super anxious and emotional or vomiting immediately after surgery. And so that clot just comes right out and they're starting at a deficit, or smoking.
I was about to say the patient population being younger.
I used to be surprised. I got some 70-year-old women hitting their vapes in my office.
Okay.
Everyone's vaping these days. Yeah, apparently it's the cool thing to do.
Gotcha. I feel like most of my probably my 50 and up patients, I think actually technically heal better because they're just on their butts following instructions versus more. Don't get me wrong, they still have their complications just because they're old and don't heal as well. But the kids just don't sit still. They get their procedure done and they're like, I got soccer tomorrow, peace out, Cub Scout, I'm doing my work, I gotta go.
I restrict all physical activity for 5 days. Strict. No physical activity, no lifting, no putting your head below your heart, and no lifting more than 5 to 10 pounds. Yeah, no. So, and that's, another thing too that can dislodge the blood clot. And so, I don't even ask my patients anymore if they smoke or if they exercise. I just look at them and I scare them and I say, there's absolutely no smoking and there's absolutely no physical activity. Otherwise, you will be coming back to my office for 2 weeks straight and I will have to continue to flush you out for 2 weeks straight. And okay. And so that's how I do it. And for your patients that do smoke marijuana, it is unrealistic to tell that person to stop smoking. I tell them to eat it. And I'm going to be candid because this is unfiltered. And so let's be honest, we're talking about a very specific patient population as well. So I don't even ask anymore. I said, just no smoking. If you really need to get high, there's enough ways to get high out there without smoking.
Just eat it. Eat it though. That's actually good. Yeah, that's actually a good alternative.
They got dabs, they got patches, they got oils, they got edibles, however you want to do it, but just don't smoke it.
Dry socket, once it happens, I'm like, what's the time frame typical that they're calling you back to say, hey, and how are you sensing that it's probably dry socket? Are you able to like get a feel for it based off their symptoms, or are you seeing them?
Yeah, absolutely. So usually the number one symptom is they were getting better, and then about 10 days later, it just started hurting all of a sudden. They usually don't have swelling, okay? It's usually no swelling, just like a really deep bony ache. And you can tell them to irrigate all you want, but a lot of times if there's not food debris in there, irrigating doesn't do as much. What you got to do is you got to stimulate blood flow. So I actually don't pack any of my dry sockets because there are reports of the eugenol pastes and stuff being neurotoxic from like a chemical perspective. And so I don't like to pack anything in there. But what I do is I literally just go in there and I flush it out real well with a bunch of Paradex so that I can stimulate and encourage bleeding. And then that's it.
Gotcha. Okay, so you're purposely you're blasting it so hard that you're trying to get some blood to kind of roll in there. Do you ever feel like you blast it and you're not seeing the blood? Like then what do you do?
Usually you put them on antibiotics. Sometimes if it's like far enough after surgery, like maybe 2, 3, 4 weeks, sometimes every once in a while I'll take some PRF and put it in there. Sometimes I'll get them numb and I'll go ahead and curette the granulation tissue to stimulate bleeding. But I don't like to get my patients numb a second time. So usually, with aggressive irrigating, stimulating that blood flow, some antibiotics, and reviewing your instructions with your patients, it usually resolves pretty well.
Have you ever just like scraped it without numbing? Like scrap, let me just get one quick scrape in here. Or like manipulation of the soft tissue. Like I always wondered this too, if we like nicked the neighboring soft tissue just to get some blood flow from that angle to start filling in. Is that not sufficient enough, or is that?
I mean, any blood flow is sufficient enough. And to answer your question, I actually remove bone spicules without any anesthesia, not even topical.
Do you know anything about like managing these with lasers?
So actually, ever since you had your laser, I've been interested in that. And so there is some evidence that it decreases the bacterial load in there. I have not heard any evidence from like an alveolar osteitis standpoint, to be quite honest. I would be really, really curious.
My only fear is that it, like a lot of times these things have like a hemostatic component to it. And like, we're trying to do the opposite. Yeah. Yeah, we're trying to get blood in there. It's almost like, you know what, actually, this is where I think, and this is what I was thinking, is like, okay, nick the tissue, get a blood flow in there. As that blood flow is getting in there, then hit it with a laser clean, and then hit it at the end to like clot it a little bit, like solidify the clot a little bit. That could be interesting.
Or you can just take the blood out of their arm and put it in there.
Oh, yeah, PRF, there you go. Yeah, I guess. Is there patients who are just like knuckleheads and it's like, blood clot pops out one after another after like you get one dry socket treatment and then they come in again, or is repeat offenders not common?
Yeah, it's usually smokers. The smokers are the one that come back time after time. And I'm like, can't help you with anything, man. You got to stop smoking, at least for a few days. And they do.
What's the longest you've had to manage of that? Like,
oh God, 6, 7 weeks.
Oh my God. And you're seeing them almost every week?
For like 6, 7 weeks. 10 days, 2 weeks. Usually
That's
2 weeks.
Still a lot. Did you start charging?
Yeah, also like sometimes too. No, I don't. I know I should, but usually too. Sometimes you got at that point also. If clinically it looks good, you got to think about drug seeking behavior and things like that, and that usually ends up being what it is, Because I'm looking at it, I'm like, dude, you're fine, and they're like, oh, but it still hurts. It still hurts, and I'm like, well, sweetheart, might be a little discomfort, but so
part of it where like maybe they're purposely popping it out or just faking it to a certain point. Yeah.
Or two, they're touching it with their tongue.
Okay. Yeah.
Chronic irritation. So you tell them to stop touching it.
The hematomas, that was a little bit, I'm honestly not as familiar with that. I'm not even going to pretend like I know what you were talking about.
It's just a blood clot. So if you got any surgical bleeding and it gets under your flap tissue and that blood clot just sits there, it's like a cesspool and it can get secondarily infected. That's why you got to make sure you got good hemostasis.
I mean, in your one scenario you were kind of painting there, you were saying person gets their wisdom tooth taken out, they're bleeding, maybe you closed up the flap and then you just injected some anesthetic material to try to get it to stop, but all you're doing is like puffing the space up. That will get infected.
Yes, it's also a false sense of security because number one, the anesthetic is a vasoconstrictor, and so it's only going to stop bleeding while it's there. As soon as that goes away, it's going to start bleeding again. And two, if you close things up primarily, then you have no place for the blood, the heme, to escape. And so that's why I never close any of my third molar sockets primarily.
Gotcha. Yeah, I remember you mentioned that on the last episode.
And it's really about technique, right? Exactly. So it's about technique. It's about, how you irrigate when you drill, the types of drills that you use, how you irrigate when you're done, what you put in the socket, the instructions you give your patients. All of that decreases your complication rate.
The hematoma complication. So how does that get triggered in the process? Like, are they calling, is it again 10 days after or is that sooner?
No, that one's usually a little bit before dry sockets. Usually I would say about 5-6 days. They're like, they were really swollen and now it's just not really going down. And they got this little kind of golf ball right here. That's usually hematoma.
Gotcha. Okay. So that's your signal. It's like, okay, I'm possibly coming in to deal with a hematoma-based infection. So then they come in. How are you treating them differently than a dry socket?
Oh, I don't. Everybody gets irrigated aggressively with monojet syringes and Pararex.
Gotcha. Okay, that's good to know.
You got to get under that flap.
Wisdom tooth complications coming in, be prepped with a syringe of Pararex or chlorhexidine and get ready to blast it like a fireman.
Yep, and usually I have them spit into a cup. That way when all that food comes out, they can see it for themselves, and then they get really grossed out, so they have a tendency to clean the areas better after. If you suck it up with your suction, they don't see it. Oh, yeah, make it drip all down their mouth, feel their own pain. Yeah, absolutely.
I'm assuming if you're irrigating and compressing it out, there's definitely a way for things to drain. Is there any times where you're like opening it up more to let it drain more?
Yep. So usually if they fail outpatient, like antibiotic therapy after their first post-op appointment, then the second time, if they're unresolved, I'll like surgically open it. But if you just take a probe or an explorer and you just kind of go around the distal of that second molar, you'll drop right into your surgical site, and then you can kind of like sneak a little tip in there and irrigate there.
And just kind of press it out. Okay, gotcha. Like push it out a little bit. That's all you need.
Yeah,
and I'm assuming not numbing it. Not numbing it, just bloop, bloop, open it up, squirt.
Yeah.
Gotcha. Yeah, squirt, yep. and then compress. You're compressing.
Yes.
Are you
and then antibiotics.
Like let's say you got a nodule.
Yes, I rub it.
Okay.
Mm-hmm.
Yeah.
You rub towards the side. And you tell them to massage it as well. That helps it.
Once they leave your office, like massage it out, keep massaging it. Antibiotics and heat. Are you normally giving antibiotics? I can't remember. Were you normally giving antibiotics?
I do not give antibiotics. So I actually give antibiotics one preoperative dose IV with every IV patient. But otherwise, I do not give antibiotics unless they come back with an infection.
Okay, and then they're coming back. So they come back with an infection. Does dry socket hematoma, does it matter, or are you giving it for both?
I don't give dry sockets antibiotics unless they're smokers. Unless they're smokers or diabetics. Those are my only two exceptions, smokers and diabetics.
Gotcha. Those get it either one.
Yes. And if you have a diabetic patient that's not healing too, get their blood sugar. Because that could be a reason they're not healing. You and I have had that a few times. Yeah, we've had patients that were very hyperglycemic. Yeah.
So the hematoma patients are pretty much always getting it. What's the first choice? First line, just Amox, amoxicillin?
I do have my own unique antibiotic regimen that I use. It's specific for which arch it is. So usually for the mandible, first case, I'll knock it out. I'll actually do flagyl or metronidazole. And if it's the maxilla, I'll do augmentin. Yeah, there's so much antibiotic resistance right now because it's overly prescribed, mainly by dentists. So I try to stay away from those broad spectrum antibiotics that have, decreased effectiveness because it's just going to prolong their postoperative discomfort and prolong me seeing them. So usually younger patients, they're not alcoholics. So metronidazole is, quick, dirty. It's a strong antibiotic, but it definitely gets rid of it in about 5 days.
I'm feeling you on that, honestly, because that's it. Like if I feel like I'm dealing with postoperative infection, toying with it at that time is always a bad idea. I feel like it's even on implants. I feel like when people get that initial implant infection, they're like, let's see. I feel like it never pans out as good as you're going to hope. And if you start being like, we're going to start less aggressive, when you have a complication, just think, we got to freaking end this. Just end it. And I think that's right. That's like on the mandible, go with Flagyl or Metro. And then on the maxilla, Augmentin. Yeah, Augmentin makes a lot of sense
Yeah,
to
or
me.
Doxy if they're pen allergic. Yeah.
Gotcha, doxycycline. Okay, gotcha. The hematoma, because like the case that you described as your worst scenario case was, I'm assuming, started as a hematoma based. Yeah, you did mention that. It was like a hematoma based type of infection. And what I was trying to egg at you too is prevalence of the two. Like you're running into more hematomas, more dry sockets.
Honestly, like I said, I really only get like 3 post-op complications a month, and it's usually just food in the sockets and like, a resemblance of a dry socket, but that's really just impacted food debris. So
Gotcha. So, do they get combined? Like, are you seeing patients who are like, oh, you got a dry socket and you got a hematoma?
no, because those are opposites, right?
Well, I didn't know if you like, well, no, like maybe a hematoma in the flap, and then there's like the socket. You're looking at the socket, and it's like that's dry as bone, but then you're swollen at the. Because honestly, this is how ignorant I am to it. I would have thought when a patient comes in that they're getting they have dry socket and they're getting a big infection from it. That's what I would have thought. That's how much
You
of a.
generally don't
I mean,
get
again, I'm not a guy that.
yeah.
Yeah,
You don't
with a
take out
dry
wisdom
socket.
teeth. I
That's
always
actually
took them out for
news
you.
to me. Right, exactly. So that's actually news to me is that when they're getting a dry socket, you're probably not getting as much swelling. And that helps isolate it out so you can kind of help with your decision tree. Now, the one we didn't go deep down in here, and I honestly feel like there's a whole episode to be made from paresthesia.
Oh, okay. I was just going to say, because I was almost going to tell you about my other terrible time when I broke the lingual plate, but I think nerve injuries should be another topic because there's a lot to go off on there. And I'm happy to, if you want, I have a great example too of a nerve repair. I'm happy to share with everyone.
Oh, yeah. No. We'll have to definitely go down the rabbit hole of nerve injury and nerve paresthesia because I do feel like that's a whole different complication.
Whole separate subject. Yeah.
Okay, this was great. You guys got probably what I would consider here the most typical complication mishaps that happen with your third molars. So again, just like as a summary, as like a pearl of how you think people should manage third molar complications. Give any kind of final words or comments on that.
Absolutely. Well, the most important thing, first and foremost, is to always have a protocol, a method, so that you are doing everything in your possibility to prevent these complications, because most complications are preventable. The second thing is communicate with your patients, okay? We swore an oath to take care of our patients and be providers. Don't just, hit it and quit it. Call them, check up on them, see how they're doing. Majority of the time, you will be able to resolve these complications before they even happen because the patient will just tell you what they're doing wrong. And then lastly, try to find someone in the community that you can use as a resource in case you do get over your head, because we all get over our heads sometimes, and that's okay. It's part of learning. But it's important to have someone that you can rely on to help you take care of your patients instead of just ignoring it, because it never goes away. It only gets worse.
Oh yeah, for sure. Exactly. Have someone who can visit them in the hospital for you
Yes,
that you trust.
exactly.
That you can have an open conversation
Exactly.
about. That'd be absolutely great. Again, thank you, Dr. V, and I'm sure we'll have you on another episode. Again, we do this for the love of dentistry, sharing our terrible nightmare stories. I appreciate that, Dr. V. Again, we are not getting paid for this. This is just for the likes, the follows, the comments. That helps us keep going and keep wanting to make more cool episodes for you guys. Thank you for getting Clinical Unfiltered. Till next time.